Hi guys, this is Tu Zhang with Clinical Medicine 2 class for ATSU University Module 3 case study. This is not my patient, but I did have a patient with Tetralogy of Fallot, and I found this case online and it seemed pretty interesting. This is a 2-month-old African-American female child who was born at full term, weighed approximately 6 pounds, 6 ounces with an APGAR score of 7 and 9 at 1 and 5 minutes respectively. Physical examination in after birth did not reveal a cardiac murmur, and pre and postductal saturations were 100% as well. She had no family history of congenital heart disease, arrhythmias, or cardiac issues. Child was discharged home at day 2, was found to be absolutely normal at that time. She went home with mom. A few days later, mom did kind of noticed some bluish discoloration at the extremities. She was reassured that this is normal acrocyanosis. The child did see the pediatrician on 2 other separate occasions, both of which seemed to be completely normal examinations, no cardiac murmur, no cyanosis. At the 2-month visit, however, the child was seen and she had a weight of 4.3 kilograms, which placed her at only the 10th percentile on the CDC growth chart. She had visible acrocyanosis, and O2 saturation was only 80% at room air. The child was sent to the ED at that time. On arrival, the child was found to be hypoxic with oxygen saturations of only 20 to 30%, and was found to be hypothermic at 32 degrees Celsius. No murmurs were noted there as well. The child was placed with an IV and received saline bolus and Rocephin. The child's blood cultures came back absolutely normal, was eventually intubated and received oxygen administration up to 100% FiO2. However, that only peaked the oxygen saturation to about 80%. Initial labs, abnormal labs that were drawn, revealed a blood glucose level of 95, a white blood cell count of 7, which is pretty normal. Hemoglobin and hematocrit was a little elevated at 22 and 68%, and a lactate of 5.5 indicating lactic acidosis. Chest x-ray at the time did not reveal an aortic knob or descending aorta, and could not rule out right-sided aortic arch at that time. The child was, because of the severity, was transferred to a tertiary pediatric center at that time. On arrival, brief TTE did show concerns for Tetralogy of Fallot. The child received additional saline bolus of sodium bicarb, midazolam, and fentanyl, and attempts to draw the blood at that time showed a hyperviscous blood with clotting almost immediately when drawn. The child was then admitted to PICU and started on a prostaglandin drip with the hope of trying to reopen the ductus arteriosus to increase pulmonary blood flow. Repeat TTE was performed and did confirm the diagnosis of TOF with a severe pulmonary stenosis, hypoplastic main and pulmonary arteries, right-sided aortic arch, and a small secundum atrial septal defect. At no point during all 3 stages within the ED, the PICU, or cardiology was a murmur heard by any of the healthcare professionals. The child continued to decompensate with worsening hypoxemia and hypotension, despite efforts with phenylephrine infusion, fentanyl, and aggressive fluids. Pediatric CT surgery evaluated the patient and decided that they were going to perform a BT shunt at that time. The child did undergo the BT shunt procedure with 3.5 millimeter Gore-Tex shunt, anastomosing the innominate artery to the main pulmonary artery. She had no complications during surgery. Returned to PICU for post-op recovery, and daily TTEs showed normal biventricular function without pericardial effusion, and flow across the BT shunt through both brachial pulmonary arteries was adequate. Post-op day 1, she was able to maintain 88% O2 saturation on room air, a huge improvement from before, huge improvement from the ED. She was tolerating feeds on day 2 post-op, and on day 4 she was discharged home with 40.5 milligrams of aspirin to help with prevention of shunt thrombosis. So on discharge, the parents did note that the child was improving. She had increased energy level. Her appearance was good. The goal is to have the infant back in the operating room with complete repair of a transannular patch at about 4 to 6 months of life. So this is a quick case on TOF. You know, as we know, TOF usually has 4 heart defects that commonly occur together. Those are ventricular septal defect, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. I'm kind of hitting my 5-6 minute mark now, so I just want to know what you guys think about the case. If you guys have had this, is not very uncommon to see, you know. So and I've only been a PA for about 5 years, so if you guys have interesting TOF cases, please let me know. I'd love to get your response back on the video as well, and sharing any interesting tidbits, cases, or facts with me.